Okay, I think we'll get started if you're all set.
Ready to go.
All right. Welcome to EMS Medicine Live. This is our August 2016 edition. So those in the South, I know your kids have gone back to school already. For mine, they're going back next week, and I've joined a group of folks who can't wait for my girls to go back. I've enjoyed the vacations and the day trips and the camps, but it's time for the kids to go back to school. So we're celebrating that this week. As I always say every month, EMS Medicine Live is made for both community and academic EMS physicians, where we try to share our ideas, our experiences, and do some board preparation for fellows and those taking their boards in the near future. Obviously, we're on Zoom. Everyone's been muted except for the presenter and myself. I don't have a second laptop with me today, so just hold your questions to the end if you could. We are recording. Obviously, you can record on your end if you wish. We will publish this on our webpage, our Facebook page, and our YouTube channels kind of become more user-friendly and easier to use videos on, so look for that as well. I do apologize. After last month, we had huge technical problems. My office computer decided to flake out 5 minutes before the talk, scrambled to get it to work. So I just got last month's presentation put up online. If you want to look at it. Again, questions at the end. And we're fortunate to have a Colonel, I'm sorry, Chet, how do you pronounce your last name? I didn't ask you.
Oh, it's Kharod.
Kharod. So I have Colonel Kharod here to present for us. He is a USAF flight surgeon or senior flight surgeon. He's emergency medicine trained and has then had ample experience with deployments and international medicine. So I'll give it to you, sir.
Great. Thank you so much, Christian. And welcome, everybody. I'm Chet Kharod, and I want to talk to you today about a topic that is relevant in our sphere of practice, in our sphere of influence as medical directors, and also probably as practicing physicians of all types. I'll start us off with this quote by Arthur Ashe. Anytime we have an idea or something that we're passionate about, many times we find people waiting till the 100% solution or all available resources are collected. And I would just submit to you that a more effective way is to start where you are, use what you have, do what you can, even if you're fielding the 70% solution or the 50% solution. It's better than zero, and then we can work from there. And that's a little bit of the story of this organizational resiliency. Now, most people, when they hear resiliency, immediately roll their eyes. I've had many of our EMS colleagues immediately tell me, oh, wellness, we're very familiar with that, doc. You can move on to the next lecture. And what I'd like to share with you today is a different take on what we have kind of perceived as wellness. So, as Christian mentioned, I'm Chet Kharod. This is our military and EMS Disaster Medicine Fellowship logo. The military has one EMS fellowship. We are a 2-year program. Our first year is accredited. And our fellows, thankfully so far, have done well on the board certification process. So it's more than a gee whiz military unique fellowship. We are benefiting from our collaboration with UT and civilian partners. So thanks to all of them. And I'll tell you, that brief bio, the last thing on there was that I was a command surgeon for the 24th Special Operations Wing. And that is a group of people who are integrated into what the community at large or lay people know as SEAL teams and Army Special Operations, etc. So this is a very uniquely skilled and uniquely selected group of people. And while I was in that unit, what we found was that there were some highly decorated individuals. They had a lot of what a psychologist might call self-efficacy. But we also found that there was a significant tendency toward relationship issues or substance use or even the extension of post-traumatic stress and into behavioral concerns that the commanders had, and then the people themselves. And we found ourselves kind of wondering, what what to do about this as we notice the pattern, 14, 15 years of ongoing deployments. And the then commander of U.S. Special Operations Command, now Chancellor of University of Texas, Admiral Bill McRaven, completed his analysis of the preservation of the force and family. And he tasked us to come up with some way to engage and rescue the people that were doing that were doing the hard work of serving those in harm's way while they were in harm's way themselves. When I transitioned over to this academic job from that operational job, it occurred to me that our law enforcement, our EMS, and fire first responders were another population uniquely at risk. So I did kind of what Arthur Ashe was saying and initiated this idea that if we presume that humans are more important than hardware, which in special operations, that is our number one tenet, then what can we do for these civilian populations at risk? So a couple of quick vignettes to kind of set the stage. I happen to know a paramedic, and she had approached me kind of from a medical direction perspective, and then out of that right out kind of discussion came this idea of ongoing relationship issues that was beginning to spiral out of control. I think we can probably look at anybody either in emergency medicine or pre-hospital services, and if you biopsy a group of those people, I think we're probably going to come across a lot of folks that have similar concerns as JK was undergoing there. A law enforcement friend of mine in a fairly high intensity job, and then if you look at our current climate of police and whether they ought to apologize or whether they ought to be taken to court for what they do, et cetera, there's so much pressure of various sorts, and this law enforcement friend of mine was self-medicating initially with alcohol and then other substances. So we found these are just some simple cases where people close to us may have these issues, and if you look at somebody, you may not even notice. Sometimes it takes a little different perspective to see that. I think our jobs in EMS certainly have some physical risks. Safety is probably, scene safety and personal safety are probably one of the bigger ones, so much so that in our incident command and other structures, we actually have a designated safety officer. So it's something we've acknowledged, but perhaps something that we can move on a little bit more methodically. We also have significant potential for physical injury. And I think if you work with anybody who's been in the pre-hospital career field long enough, or they've been in long enough, then we're going to see people who have back pain or knee pain or other things. So, certainly a potential for injury, whether it's scene safety or in the actual service of a person. On the physical side, we also have, from the leadership and management perspective, there's always the workers' comp issue. Did this happen in line of duty? So many of the physical aspects of our well-being are, maybe we have a concern about them, but I would submit to you that maybe we're not addressing them quite as well as we could. When you consider the human being, and the slides here are going to show physical, psychological, spiritual, social, and this is the model we were using in the U.S. Special Operations Command, kind of mind, body, spirit. All of us would agree that stress is probably somewhat beneficial, provided that it's not overwhelmingly acute and that it is not so chronic that there's no escape from it. So we begin with some beneficial aspect of stress, but whether it's acute or chronic, it is there. In my review of this body of knowledge, there's a significant amount of work done on acute stress and dealing with like a spike of stress and what happens after the fact. There's probably a less methodical look at what chronic stress can do in each of these domains, though we all talk about type A versus type B personalities, and those concepts have been around for a while. With enough stress, we can certainly move into the realm of post-traumatic stress, or really anxiety is another one that is a key manifestation of people who have undergone something significant And it may manifest itself by either a reluctance to want to go to work, or you feel like you're not that excited about it anymore. We recognize some of these symptoms, but our culture is such that I can't imagine a firefighter or a paramedic actually leaning over to their partner on the ambulance and say, gosh, I've just been very moody lately. That just is not tolerated in this culture. It's not really welcomed. And probably in emergency medicine as well. A lot of this is perceived as weakness and things that we should just work through. And even speaking with my mentors about this topic, just as recently as this week, one of the senior physicians I was talking to was like, well, it all comes down to, goodness of fit. You're either strong enough for the job or you're not. And I didn't want to be too contentious, but I have to disagree with that. I think no matter how strong you are, our world is one in which we routinely patrol through the areas of experience that are well outside normal human experience. And I think it's healthy for us and appropriate for us to acknowledge that when a normal person encounters abnormal things often enough, there will be some toll associated with that. One of the tolls that we find is depression. And again, in high-performing individuals, depression does not always manifest as being quiet, withdrawn, or otherwise kind of lower key. Sometimes it presents with anger or the inability to make decisions in as timely a way as they're used to. So, and then it can manifest also in substance abuse or other ways in which people try to manage that stress or that depression. Most of us are aware that as this progresses, we generally sit up and take notice when there's a suicide. And if you've looked at the numbers recently, it's quite concerning. There have been more firefighter deaths in the last 10 years trending upward by suicide than there were firefighter deaths on the fire ground in the line of duty. And then it's similarly more law enforcement deaths by suicide than there are by them being in harm's way. And obviously the military, we have a huge anti-suicide campaign, and the leaders are frustrated because it's not really changing the numbers of the suicides. So I think suicide is the extreme that we see for people that are in psychological distress. But I would submit to you that recognition is only part of it. Active prevention is probably where the answer is going to lie for that. When you look at our communities, I remember being a fourth-year medical student and having our dean tell us that 4 out of 5 physician marriages end in divorce. When I talk to paramedics here in San Antonio, many times they will jokingly say that, yeah, that was my starter marriage, or yes, I'm now in marriage 2.0, the debugged version, I've upgraded my software. There's so many different comments that will be made. And I think it speaks to the idea that when you're a shift worker, when you are working in this acute stress kind of environment, when you are isolated by constantly having to be the cup of strength to all these suffering souls, then certainly there can be some distancing or compartmentalizing. How many times have we come home from a shift and felt like you walk in the middle of a conversation? Your spouse or your significant other wants to talk to you about the events of the day, and you're still thinking about the 4-year-old that you all tried so hard to resuscitate. You transported with the resuscitation in progress, and then was pronounced at the hospital soon thereafter, and it weighs on you. And it's difficult to express, right? So we want to have that conversation with our support network, but at the same time, we don't want to darken their doorstep with that either. And this leads to communication issues and social isolation as well. So we talk about wellness in our community. And when I brought this up here, the first response was, hey, we have a wellness center. And, they do a very good job, actually. They do the annual physical exams. They have their door open for nutrition information, and everybody should exercise and try to eat a rainbow every day. And these are the efforts that are kind of the norm, though we are now seeing pockets of change. So typically wellness centers around occupational health, right? So in our industry, it might be lifting training, and have you been exposed to a certain amount of toxins? If you're a corrosion control worker in the Air Force, for example, then I'm going to be checking your blood chromium levels and get a chest x-ray on you. So we tend to look at occupational health almost as a subset or a separate set of the health of the individual. We definitely check the plumbing with the blood work of all sorts. We can prescribe medications or prescribe lifestyle changes to the folks, but I'm not sure we check the hardware quite as well as we check the plumbing. And if we do check the hardware, it's almost like we auscultate and maybe check the skin, but we're not really looking at whether this person is fit for the job that they are doing and how can we address that, right? And then the software, I don't think we really look at. I think we do some selection on the way in, and then in the handful of places where I've spoken to folks so far, it is anecdotal, but I get the feeling that if you're doing fine, then you're doing fine. And it's difficult in our culture to address it in any other way. Now, I would submit to you that this is kind of the glide slope that we're on, to use an Air Force term. If the business of EMS and its personnel is a plane, then this is kind of the vector we're currently flying on. What I'm hoping to introduce and to energize in our community is this idea of preservation of the force and family. And that's what Admiral McCraven had named it. And then he turned around to his subordinate commanders and said, make this happen. So Air Force Special Operations, Navy Special Operations, U.S. Army Special Operations, and Marines all came up with some customized plan that fit their community and their personnel. So if you take the example of a Special Operations Forces warrior, most of what we know is probably from the movies, but I would submit to you that these are people who are highly intelligent, very interested in successful execution of their mission, but they tend to be quite devout, and they are very much committed to their team and also to their family. So they're not it's not necessarily Maverick from Top Gun, if you remember that reference, or it's not necessarily Charlie Sheen in Navy SEALs. They're not all ridiculous risk takers, even though there is a significant amount of risk involved in their job. And to a certain extent, we select for the personalities that are risk takers. And there's a similar selection process if you look in EMS, though it may not be the exact same personality that we're selecting for. We pick a certain kind of person to do these jobs. And then we probably need to have a program that supports and strengthens that kind of person. So in special operations, our approach was, let's develop physical resiliency. So the first thing we did was a task and demand analysis. What is it that a combat controller has to do? What does a pararescueman have to do? What does a Navy SEAL have to do in their job? Imagine if we were to say, what are the 15 physical movements that an EMS medic has to perform in the field? And then we come up with a fitness plan arranged by athletic trainer or a strength coach that says these movements that you train in will suit you in the 15 or 20 things you have to do in your job every day, right? So it's not just CrossFit, or it's not going to the weight room, or it's not nonstop cardio. We can see that their posterior chain muscles in their lower extremities are weak. The core might be weak. There's a lot of sitting, so their hip flexors are hyperflexed, and it further passively weakens the posterior chain, all of which is needed for patient movement and working in the field environment. So add to this performance nutrition, teach our people how to eat for a 24-hour shift or for night ops. We do all these things with great success in special operations. And I think that is a translatable model to anybody, either pre-hospital or anybody who's doing shift work, or really any profession, particularly those in medicine is where I've been looking. So there's a way to train for this. Of course, my leaders always wanted to know, how many injuries have you prevented? And I kept saying that's not a really measurable metric. What we should look at is return to duty time, because the job didn't become any less dangerous after we started this training. But there is a value to maybe taking this methodical approach. Similarly, for psychological resiliency, all of these young men are in the pool, and you can't see it there, but their masks are full of water as well. So they are being challenged to coordinate multiple kind of dangerous situations. They're treading water in a 8 to 12 foot pool, and they can't really breathe in through their nose because the mask is full of water. So it is a physical challenge, but a lot more of it is, can they hang in there? Are they tough enough, and do they have enough resolve to complete this challenge, right? So we're not talking about challenging our people this way, but what if we were to create an expectation and educate appropriately and say, hey, you are entering a world where, number one, you are going to be of service all the time. Number two, it's not going to be all glory and guts all the time. You're going to get a significant amount of movement of patients where you may feel like a taxi service. Let's be honest. It's going to be ebb and flow in terms of intensity. And we have to imagine that we're going to do this, because most of our recruiting campaign tends to do the opposite, where we show kind of the guts and glory side. And then folks, even in their second year, are feeling like they are victims of a bait and switch. They have no stamina to work through the early part of their career, or they get super invested in the uniform and they can't imagine their life outside of that uniform. 20 or 30 years later, they've never developed anything else. They don't have anything else, and then they're done. So if our objective is to get optimal care to the patient and longevity for this provider, then psychological resiliency, adequate kind of preparation, and ongoing contact are all going to work. We did this by having operational psychologists in the units, and then we also had social workers and family life consultants available on call to manage family issues or to help coordinate those. Sometimes it was simply, the shooter, as we call them, the operator was deployed and the family had a lot of things that they were trying to work through. So there is some power to this model where we can educate not only the person doing the job, but maybe their family as well, right? And then we found that having a chaplain in our special operations wing was a real game changer. JB was our chaplain, and he not only was able to connect with everybody from his own faith, but he created this environment of understanding and just counseling sometimes from a non-judging person that really yielded surprising results. Our families definitely benefited from this spiritual resiliency. I mean, so many times that 4-year-old that I was telling you about was a very sad case that happened just last week when I was taking call, and it was an unresponsive 4-year-old they tried to resuscitate, and we were presuming that it was a respiratory cause for his cardiac arrest, and we had our PALS kind of algorithm and process, and we're doing all this in transport. And in the days that followed, we found out that it had been we had looked for signs of bruising or non-accidental trauma and had not seen anything, but it was the worst kind of non-accidental trauma. This child had been thrown so violently against some furniture that he had a vertebral fracture and a ruptured aorta and died that way. And it was terrible for the team. Even at the time, they felt so helpless being on scene. And then we found all this out, and we basically kind of talked on the phone afterwards and face-to-face whoever wanted it, just to kind of express our feeling of helplessness and a little bit of frustration, maybe some outrage that a child was treated this way. It helped everybody involved if they had a sense of there's a cause greater than ourselves that we're serving. And we were definitely not all of the same faith. So I think there's a role for this spiritual resiliency, however it shapes itself. And then finally, we are a community of social kind of organisms. So we all interact with each other. Relationships trump so many other interactions that we have. So the social resiliency is something that we really emphasized in our special operations piece. And the way we did that was we not only engaged with the uniform member, but we also had opportunity for spouses and others to get together. We had family retreat as an opportunity, but we also had separate ones where when the teams were deployed, we met with the families. So there are opportunities like this where we can build a more stable base for our community. So this was the Special Operations Command model. And I'll tell you just a brief story of this American hero here. He was a combat controller. He was the air-to-ground support communicator for a mission that they were conducting. Their job was to go find this person who had been responsible for a lot of the kind of terrorist work that had been done against us. So they're out there in this village, and in his role as the communications guy, but also an operator, he was shot multiple times that day from a hut that was right nearby. One of the gunshot wounds was through his chest, and he realized that he's having difficulty breathing. He continued to call in air support. He'd also been shot in the arm. He applied his own tourniquet. So he sustained multiple significant injuries and then was evacuated out of that situation and through the military kind of forward care system back into home station care in the US. He recovered physically up to a point, but then he was referred into physical therapy, kind of in traditional models of physical therapy. And for a combat controller, activities of daily living are a foregone conclusion. That's not what he was looking for. He was looking for, multiple pull-ups with a 100-pound kit on. He wanted to be able to run with his body armor and all these things. And that was not where his physical therapy was taking him. So the reason I'm telling you about him is he ended up recovering quite well. He was presented with an Air Force Cross, which is the second highest medal for valor for the lives he saved that day while at personal risk. It was a great day for him to meet with the commander-in-chief and to be acknowledged that way. But his comment afterwards when we kind of met back up with him was, hey, I was in the regular military health system and I just wasn't getting anywhere. When I got back to special tactics and our resiliency team of physical therapists and strength coaches and counselors and all were able to get a hold of me, I had daily contact and I was back in 2 months. Now, he's exaggerating a little bit that process of healing would have taken as long as it was going to take. But imagine if we had a similar system where we use the current resources that we have, and then we also add in some of these specific pre and post and ongoing specialty care opportunities. Now, you may say, I've seen something like this before, and I'll tell you there are grassroots growth of things like this around our country. But the number of resiliency centers that are comprehensive mind, body, spirit, and social for first responders in our country are exactly 0. So we are expecting a lot from our personnel, and we haven't yet figured out how we're going to maintain or support them with this sort of a comprehensive program. And it's not because we don't care. I think it's because this model is still being developed. Now, there are a couple of examples from here in Texas, and I know there are others around the country. So the Department of Public Safety has a SHIELD program, Strength and Honor in Everyday Lawful Decisions, and that is run by a state trooper and somebody who previously worked in the Army's tactical athlete program. So these programs focus on social and psychological resiliency. There's another one at Cypress Creek EMS in Houston. They have partnered with the Ironman Sports Medicine Institute, and they have a physical resiliency program for their tactical team. So body composition analysis, nutritional analysis, strength and flexibility screen, and then a task and demand analysis as if they were elite athletes, and then moving toward that. Here in San Antonio, we have the POWER program, Performance Optimization with Enhanced Resiliency. It's in its earliest stages. We have a great peer-to-peer support program, peer counseling. We have very good stress education. We have not really moved into the physical resiliency or even spiritual resiliency. One of our goals this year, though, is we're going to engage our fire department chaplains. There is a social arm to this. The spouses have a Facebook group and are beginning to start with kind of spouse gatherings as hosted by the department. So there are some examples. But as of today, I would submit to you that our vehicle maintenance is more systematic and gets more attention than our human maintenance. And I think we as medical directors probably have a bigger role in this, though we may not own the budget. I think our sphere of influence is such, and we're coming from the area of humans are more important than hardware, that perhaps we can influence change in this direction. And what we need is an organizational approach, not an individual approach. And the pillars are the ones that you see here. Obviously, wellness is a part of this. Social, psychological, physical, spiritual. These are the pillars that we can build this on. We're not going to do it without partners. Every knowledgeable person listening, and I myself, are all saying there's no budget for this, right? And you're right, there is not a budget built in for this. Here in San Antonio, as an example, We have approached some of our professional teams, and while the initial approach probably was not high enough, meaning if the CEO of the Spurs had been engaged, there might be a little different interest as opposed to the business manager of the Spurs who's interested in the bottom line. So these are potential routes of funding or support. Sports teams, private sector is certainly another one. These are some major multi-billion-dollar companies that have headquarters or offices in San Antonio. So this fall, we have a couple of meetings scheduled, and my theory is that if the CEO of HEB commits something, call it 5 figures, whatever it is, to a resiliency program for public servants and first responders, I'm pretty sure that the CEOs of these other large organizations will not want to be left behind. That's an untested supposition, but that is the approach that we're going to take, and I'm working with the fire chief's office to see if we can make some progress in this direction. Now, the final partner that I think we can't overlook is academia. Texas A&M's physical therapy school is very interested in doing some work with our first responders. The only thing they want in return is not money, but they want to be able to publish what they find, right? They want to do some performance improvements, some clinical investigation, as do the other universities here, Baylor and University of Texas. So the details of that have not been worked out, but you can see that there's a broad base and a potential for partnership that is really there and can make this program a reality instead of just a special operations program. Now, I think there's 5 things we can all do even now that before we wait for the budget or the partnerships to form. So let's talk about those briefly. The first one is breath control. Whether you're a martial artist, a sniper, a woman in labor, there are so many applications of breath control, and the science is pretty clear on this. You can control your heart rate and affect your circulating catecholamine levels and neurotransmitter levels by getting your respiratory status under control. So when I find myself in a stressful situation, I remind myself to breathe the box. And I'll just show you how that works here. The concept is predicated on what's called diaphragmatic breathing or belly breathing. So most of us, when we take a deep breath, the maximum exertion in our torso happens at the chest or thorax level. And we really want the maximal exertion to be in the abdominal level. So I teach our paramedics and our chiefs, even the battalion chiefs, that they should put a hand on their chest and a hand on their abdomen, close their eyes and take a deep breath, and pay attention to which hand moves more. If your chest hand is moving, then you're breathing in the sense that you're having gas exchange, but you're not breathing in the sense that you're actually breathing naturally and having the secondary effects of breath control. So once we master this physical skill, it is all about muscular coordination, then we can breathe the box. And the idea there is we breathe in for 4 seconds, which is one side of a square. And then you'll see it here. Breathe in for 4 seconds, and then hold for 4 seconds, and then breathe out for 4 seconds, and hold for 4 seconds. Even 3 cycles of this controlled and measured breathing can have a significant impact on the heart rate and the level of stress that we're perceiving in that situation. I would encourage that you give it a try. It works surprisingly well. One of my most skeptical firefighters wanted to know the physiology of this and the psychology and how it overlaps. And I said, I'll tell you as well as I know, but I'll tell you after you explain to me how an internal combustion engine works and how the current flows in a light switch. And he goes, I'm not an electrical guy, Doc, I don't know. I said, exactly. And yet we are able to effectively use these technologies every day. So if you're able to hit a light switch and use the light, you don't need to understand how Breathe the Box works. You simply need to use that tool to help yourself. So there is some skepticism, and I didn't mean to dodge his answer, but my point was sometimes we get more skeptical about things that have a behavioral modification involved as opposed to all of us crank the engine and drive away every day. In fact, we only notice it when it doesn't work. So we have this tool available, and I would encourage you to practice it and make it something else that you can hang on to. The other thing is sleep. Now, I'm a self-proclaimed expert in sleep, and I don't mean in sleep study or sleep science. I mean, I can close my eyes at any time and get beneficial sleep right then. And at the same time, I'll put an asterisk next to that. I'm probably spotlighting myself as somebody who's sleep deprived by saying that. Now, this slide is going to give you probably a career's worth of sleep study knowledge in one slide. If any of you are experts on this, please don't fill up the chat box with where I got it wrong. It's a conceptual slide. So if you look, these are the stages of sleep through which we progress in the course of the night. The red line is the line of awakening. So we fall asleep there on the left side, and that arrow that just formed over there is our kind of our pre-sleep routine. And most of the time when I teach this, I ask the paramedics, what is your pre-sleep routine? And there's a lot of nervous laughter, and people will joke and they say, usually it involves a beverage and things like that. Some people say I just keep watching TV till I fall asleep, or whatever their answers are. And I use that to kind of spotlight this idea that, when we were children, we probably had a pre-sleep routine. But as adults, we've kind of lost that, and we don't glide into sleep. We usually slam into it like it's a wall. And then we expect it to do something beneficial for us when we kind of enter it roughly, and then we exit it too soon, and we don't really get the benefits that we ought to get. My kids are a great example of this. I have a 10-year-old who must check all sports scores and have full visibility of the latest happenings before he goes to bed. So I tried unsuccessfully to kind of wean him of this. And then I just realized this is part of his glide slope. He's going to glide into sleep like this. Check the scores, brush your teeth, we say our prayers, we go to bed. And it works. My other one is 7 and has a monologue that he has to give every night. It's not fair. Why do I have to sleep? You get to stay up. I'm going to miss all the fun. Again, trying to rationalize with a young child, I realized that my wife probably feels that way when she has to rationalize with me. So instead, I just let him have his monologue, and I just quietly listen, and we hug, and then we brush our teeth, change our clothes, get in bed, go to sleep, right, after our prayers. So having a sleep routine is powerful. Now, if you stress a person enough, watch what happens to our line of awakening. These are micro awakenings where you break through the threshold of sleep and awake a status throughout the night. And then you wonder why your workout plan and your nutritional plan don't work. Your memory is not fading because you're old. Your memory is fading because your brain doesn't have a chance to process memories at night. You never even entered the stage of sleep where memory functions are enhanced and immune function is restored, right? So sleep is critical. So breathing the box, learning how to sleep, exercise, visualize success in the shift. I make my residents take a pause before they go in and start seeing patients. And I go, what are you going to do today? They're like, I'm just going to grab charts, Dr. Kharod. I'm like, yeah, you're going to be the cup of strength to suffering humanity. And they're like, right. But we have to visualize that something greater that we're going to do. It's okay to visualize the stressful part of it too. But I think if we can visualize, that's what elite athletes do. An Olympic lifter is not visualizing the struggle to get the weight off the ground. They're visualizing the final successful movement of that weight. The runner is visualizing crossing the finish line first. So we also can use the power of visualization. And then finally, I think it's important that we normalize this topic. There is an undeniable load of stress that our people are carrying, and we have a capacity to take an organizational approach to this individual resiliency. After my first lecture on this, I actually got a text that scared the living daylights out of me. It was similar to, I don't know if I'm going to make it, like you see on the screen there. I ended up just meeting with this person, but there was a clear desperation. And when we first brought it up among the leadership of the fire department, there was some concern that I had started something. And I don't think I started it. I think my bringing it up in public allowed somebody else to bring their issue up in public. So I think there's some sense of can of worms that our leadership may feel when we do this. I also share this number with all my first responders and say, hey, this is a group of people that answer our kind of people and the work we do. So I share this number all the time. That person who texted me ended up being fine in the acute sense, and then also fine because the fire department and the EMS chief were very flexible in how we pursued the follow-up and care and support they needed. 2 years later, I still get an occasional text from that person, but I think that there's a role we can play as medical directors in leading and influencing both up and down in this. I'll close with my final thoughts here that whenever I reach a situation like this, I ask myself, if not me, then who? And if I'm not going to address this now and fix this now, then when is it going to get addressed? I remind myself every day that humans are more important than hardware. And even though I get buried in the administration and sometimes get tripped up by folks that I perceive as not trying as hard in their job as I'm trying in mine, when I remind myself there are things I can do and there's things I must do, I usually end up with a little bit more progress and a little less stress. So I'll leave you with my information. I welcome any of your inputs and thoughts, any questions you may have. I absolutely want to hear if you have something like this that you're developing that you can share. And then I have some interest in also collaborating with folks outside of Texas. So please do share your interests and your experience. Thank you very much.
Thank you, Chet. That was really interesting. I guess I have just one question off the top of my head. Working with a physical therapist to develop a strengthening program, are you still developing that, or has that been done before?
So that's a great question. In the special ops world, we were able to do it by actually hiring a former NBA strength coach and later a former NFL athletic trainer, and they actually did the motion analysis. University of Pittsburgh came down to Air Force Special Operations and did a kind of a wholesale task and demand analysis as part of a grant study that they were doing. My local plan, we have not developed this locally well enough, but my local plan is with the University of Texas and Texas A&M. Both have expressed interest in kind of letting us work with their kinesiology departments to develop something. So we're not there yet, but we have a vision on it.
Interesting. Okay. Let's see. Usually I unmute everyone, and that's kind of turned into a little bit of a disaster in the past.
Okay.
If there's any questions, you want to unmute yourself and ask them now, as opposed to me trying to unmute everyone, which causes some mayhem. I'll give you a couple seconds. And no. Okay. I want to thank Chet for this talk. I think this is hugely interesting. And I'll admit something perhaps that I've neglected at my work as a medical director in the past couple of years. You know, you think so much about protocols and medicine and training for patients that, you know, coming back around to the providers and these kind of ways is interesting and something I'll have to look at again and talk to my partners about too. So thank you.
Thank you so much. And I just wanted to compliment you on EMS Medicine Live. It's a brilliant idea and one that I want to thank you for having me on. And we're hoping to link up with you again in the future. This is fantastic.
I will hold you to that. We're making our 2017 schedule. So
okay.
Back around. We do have, let's see, Chad Nesbitt from Penn State doing mechanical CPR devices next month. Jeff Lubin from Penn State's doing November. When I was doing this slide, I'm not sure what the problem is here, but Brian Clemency did volunteer for October, so I just reminded him today of that. So we'll find out what topic he's doing. And then we have David Tan and David Cohn come up in December and January. I will put a pitch out. We are making our 2017 schedule. If anyone has a topic they want to present, or as Craig did, found someone else to present for him, please contact us and we'll discuss your topic and if we can get you onto our presentation. So again, thank you to Chet, and look forward to seeing you next month.
Thank you.
And stop recording.